Hello, and thank you for the opportunity to participate in GIE's author interview series. My name is Huapyong Kang, and I'm an assistant professor in the Department of Gastroenterology at Gachon University Gil Medical Center. I'm honored to present our research on the efficacy and safety of EUS-guided FNA in patients with suspected gallbladder cancer. Gallbladder cancer, a leading malignancy in the biliary tract, presents a challenge in most patients due to its unresectable nature. Tissue acquisition is difficult because non-invasive transluminal approach or intraluminal approach is impossible, but it is also critical for confirming diagnosis and planning treatment in such unresectable cases. And it is sometimes required before surgery in resectable cases, especially if significantly invasive surgery is anticipated. While EUS-guided fine needle aspiration and biopsy is a common tool for other pancreatobiliary malignancies, its application for gallbladder cancer is less prevalent. Past studies have shown promising sensitivity and specificity, but most of the population used EUS-FNA only. Now we are in the era of EUS-FNB, but there is a significant lack of evidence supporting the use of EUS-FNB in patients with gallbladder cancer. In summary, obtaining tissue samples for gallbladder cancer remains challenging, and EUS-FNA plays a vital role in cytological diagnosis. So our hypothesis posits that EUS-FNB may offer valuable cytopathological insight and a favorable safety profile, whether sampling from the gallbladder or other sites. And the aim of the study was to assess the diagnostic performance and safety of EUS-FNA in patients suspected of having gallbladder cancer. We included adults suspected of having gallbladder cancer who underwent EUS-FNA. The procedure was performed in various sample sites, including the gallbladder, lymph node, and liver. And our exclusion criteria were patients with confirmed primary tumors of others than gallbladder cancer, those lacking final diagnostic information. We conducted a retrospective study analyzing over 13 years of data from 3 tertiary hospitals. In such studies, defining diagnostic criteria is crucial. In our EUS-FNA report, any mention of consistent, suggestive, or suspicious of malignancy was considered as malignant. Anything else was considered indefinite result due to the high risk of false negative results. Final malignant diagnosis was made by malignant result from tissue acquisition like EUS-FNA or surgery. Final benign diagnosis was made by surgery or more than 6 months of imaging follow-up. Out of 170 patients, a majority had metastatic disease. Patients without a gallbladder sample were more likely to have smaller lesions, wall-thickening lesions, and lesions located in the fundus with less extensive liver invasion. Looking at procedural characteristics, the gallbladder was the most common site sampled, followed by lymph node. Most procedures used needles of 22 gauge or thicker, with 25% using the finer 25 gauge. FNB needles were employed in almost 70% of cases, with an average of 2.7 punctures per procedure. For mild bleeding was the only adverse event noted, and there was no instances of needle track seeding. EUS-FNA demonstrated high diagnostic efficacy with approximately 83% sensitivity and 84% of accuracy. Ultimately, 96% of the final diagnosis confirmed as gallbladder cancer. This table illustrates the diagnostic performance by procedural characteristics, notably the use of FNB needles and needles thicker than 22 gauge provided significantly higher sensitivity and accuracy compared to FNA needles and 25 gauge needles. To summarize our analysis, using FNB needles in 70% of study population, EUS-FNA has a high sensitivity and accuracy of nearly 85% of gallbladder cancer diagnosis. FNB needles and 22 gauge or thicker needle showed better outcomes than FNA needle and 25 gauge needle. We also observed distinct region characteristics in patients who did not have primary gallbladder samples. These characteristics seem to reflect the possibility to other easily accessible regions, such as lymph node, as well as the characteristics of difficult-to-target gallbladder primary regions. Integrating these distinct features with safety measures for EUS-FNA-B, we have proposed an algorithm to identify optimal FNA-B targets in patients with suspected gallbladder cancer. This approach has the potential to enhance both accuracy of diagnosis and procedural safety. In conclusion, EUS-FNA-B is safe and highly effective in diagnosing suspected gallbladder cancer, regardless of whether the gallbladder or lymph nodes are sampled. Our findings endorse the use of 22-gauge or thicker FNB needles over 25-gauge FNA needles, and suggest that when gallbladder targeting is challenging, lymph node may serve as an alternative target with similar diagnostic outcomes. We hope our findings encourage more widespread use of EUS-FNB in diagnosing gallbladder cancer. Thank you for your attention.